I want to welcome everybody to the Building Your Healthy Hospital Operations webinar that TeleTracking is presenting today. So we're going to give it another couple minutes for people. They're signing in as we are here, and we can't wait to get this started. There's going to be a lot of exciting information that we're going to be sharing from Upstate Medical University. So we're going to wait until everybody gets signed in. And I see people continue to sign in as we're talking. And I just want to welcome you to TeleTracking's Expand webinar series, which is Building Your Healthy Hospital Operations. And we are so excited for today's webinar speaker. We're going to wait just one more minute and then we'll get it started. This is like lunchtime, hopefully, for many people that are signing in. So hopefully you can be able to have like a lunch and learn, while you are listening to the speaker. I don't want anybody to choke though, because it's really crazy outcomes that the speaker is going to be talking about. So be very careful, and it is time. So I want to officially welcome everybody to the TeleTracking Expand webinars. And our series is going to be Building Your Healthy Hospital Operations. I am so very excited. My name is Maria Romano. I'm the Global Clinical Executive at TeleTracking. And today we have a great presentation to kick off our webinar series. It's Admissions Start with Discharges. And it's Kyle Chiquette from Upstate Medical University, who's going to be speaking about some outcomes that he has been driving with his hospitality discharge center. So if we can just advance that slide, it would be great. I want to make sure that everybody that's signing in realizes that you are all muted for right now, just in case you got some background noise going on in back of you, people asking for beds, things like that. So you are muted, but we want to make sure that you are participating by asking questions. So if you want to type in a question, just click that Q&A button that's right at the bottom of your screen, and we will see that question come up. And we're going to wait until Kyle gets through, the entire PowerPoint, and we will ask those questions accordingly. And then if you need any help to configure that audio and other settings, which I needed earlier, please click the audio settings in the bottom left-hand corner, and you'll be able to do that without a problem. So just as a reminder, everybody is muted, and we'll continue on with that next slide. I can't wait. So again, welcome for everyone that has just signed in. We are going to hear firsthand how Upstate Medical University improved communication with TeleTracking Technologies to improve their discharge process, which I'm sure all of you can't wait to hear this, because each one of us that are on this webinar right now deal with problems with that discharge process. There's not one hospital that I work with that doesn't have a problem with the discharge process. So we are looking, we're going to be able to listen to what Kyle Chiquette has to say with his outcomes. And we're going to be learning about that Discharge Hospitality Center that we had the opportunity to partner with Kyle and his entire team at Upstate Medical Center in building with the outcomes. The next slide, please. And so today's speaker, as I said, was Kyle Chiquette, and he's the Associate Director of Nursing of Throughput Operations at Upstate Medical University. I have had the lovely opportunity of working with Kyle since August 24th, 2021, when he went live with TeleTracking. And ever since then, it has been quite the journey, Kyle. I'm sure you will agree with that, with everything that we have partnered together. Your electronic medical record is Epic, and we have partnered closely with making sure that we have outcomes built with your EMR and with this Discharge Hospitality Center, and I can't wait for you to share all of those great outcomes. We also have on with the team Lisa Gray, who was a consultant that helped Kyle throughout the journey, and she's from our advisory services at TeleTracking. And also is Mike Maxino. So we have truly an interdisciplinary team here working with Kyle at Upstate. And he's the manager of client delivery and teletracking. And we're really grateful that everyone could get on this webinar today to be able to speak to the outcomes that Kyle has been driving with his team at Upstate. So I'm going to hand this over to Kyle. And Kyle, are you ready?
I am.
All right.
Thank you so much, Maria. And thank you everybody for your time today. I know everyone is really busy with our care in the world today for our patients. So thank you for that time that you're gonna give us today to review what we have done here at Upstate. And Maria, you're right. It's been a long process. We implemented teletracking in the middle of the COVID pandemic. So some people often forget that it was a very big lift, but we were able to do that. And we are seeing great results because of it. So today, I just wanted to give you a quick overview of what our hospital health system is. So we're in Syracuse, New York, upstate New York. We're the only academic medical center. We serve a huge clinical catchment area, 19 counties. It spans from Canada to Pennsylvania to Albany to Rochester, and it's very rural. There's not a lot of hospitals, but it's a very, very large area that we cover, and about a population of 140,000. So we have 3 hospitals, over 770 licensed beds. We have a level 1 trauma center, burn center, poison center. And there's a breakdown of our 3 hospitals. Upstate University Hospital, that's our main downtown campus. That's in the city of Syracuse. Our community hospital is outside of the city, so it's more of a community setting hospital. Upstate University Hospital has residents where community hospital does not have residents, and I'll explain why that's important and something we did later on. And then our Children's Hospital is 71 beds, which right now is very, very busy with the respiratory season that is happening in our pediatrics. And I wanted to tie a piece of our hospital vision in because we tied this into our product vision, which I'll share, but we'll provide comprehensive, seamless, and innovative patient and family-centered healthcare to improve the health status of the communities we serve. And this is important because we wanted to include the patients and families in our process and not just have a process and for the patients, but actually include them in what we do. And we thought that was a way to do that was to get better results is including them up front, having those conversations with the patient and family and bring them in to have that patient and family-centered care, which is super important to us as a Magnet organization. And you can see our throughput operations motto, which we try to follow: right patient, right location, right service, right time, every time. And then read it, believe it, do it. So it's very important for us to get the patients to the right area so the next patient can get that care that they need. So it's always about moving the patients along the continuum to get each patient the care that they need to get that they can't get otherwise unless they're in our facility. So admissions start with discharges. So the title is important is, we can't get patients into our health system unless we get patients out of our system. So in order to get patients out or to get patients in, we have to get them out. And what are we doing for that process? So we developed a project problem statement. So low discharge before noon percentage leads to increase emergency department boarding and diversion. And we knew this is an issue for us. We can't get patients out early in the day, which backs up the ED, backs up the PACU. And then we can't take external transfers because we don't have those beds available. The ED starts boarding and just backs up, and then we're in a place that we're stuck. So we needed to find a way to get patients out earlier in the day and help open up those beds earlier because we know that staffing in the evening decreases, EVS staffing decreases to now allow us to clean beds more efficiently when we have more staff. So it all ties back together in how we move patients through the continuum. We developed a mission statement, which was to improve the efficiency and patient throughput by discharging patients on time and effectively communicating to the multidisciplinary team. This coordinated effort will assist in timely discharges, improve wait times, and promote patient-centered care. So there's a couple key things here. It's the multidisciplinary team. We knew we couldn't do this just nursing focus or just physician focus or just case manager focus, that we needed to come together as a team to really solve this problem and move it forward in the right direction. And then that last thing, that patient-centered care, involving the patient and the families in this coordinated effort to be able to ensure that it's a seamless process. We were very regimented, siloed, and not working together as a team, not communicating effectively. And we found that communication is absolutely an area that we needed to improve around this process. So this project started with a multidisciplinary discharge Kaizen, which included administrative supervisors, case management, bedside nursing, nurse practitioners, throughput team, social work, therapies, PT/OT and speech, pharmacy. And just for those that don't know what our throughput team is, that's a specialized subset of our nurses that are trained specifically to do admission histories and discharges on our patients to move them, help move the patients through the continuum of care. They help the bedside staff moving patients along, which has really been valuable. But the key piece of this entire project was the TeleTracking advisory services. Honestly, without these services, this project probably would not have started and would not have been successful. The advisory services led this discharge focus group. We met for an entire day. There was around 50 people from all these areas, maybe a few more that I didn't mention, in this room, and we went through all the problems of a discharging patient, starting from admission through the discharge and what each avenue of source of error that could have happened. And TeleTracking advisory services led these conversations. And then we came together after that and said, all right, these are our problems. How can we fix these problems? And the advisory service led the group in coming up with a solution and the interventions that I'm gonna share here in a little bit. And then they didn't finish there. They came back. So the advisory services kept coming back as we were implementing, as we were post-implementation to review, to look for changes for improvement. So without those advisory services, this project would not have been probably started or has been successful as it has been. So truly thank TeleTracking and the advisory service for helping along in this process. It was amazing to have them, work with them. It was great collaboration between the groups. So out of this session, we were able to identify several barriers, and we kind of grouped them into 4 main categories, in which are here. So lack of communication between the team on discharge readiness. We found that, nursing said, all right, this patient's ready to go, but physicians would say no, or vice versa. Physicians say it can go, but nursing's like, no, it hasn't had bowel movement in 3 days. The patient can't go until they have bowel movement. So we were lacking communication between the team to know when those patients were actually ready for discharge, which was very troubling for us. That how can we work together on the unit bedside, but we don't know what each team is doing. We don't know what is being communicated, and we don't know who's actually ready for discharge. So how can we discharge patients if we don't know who's ready to discharge at any point? And this led to another big thing. We actually had no formalized process for discharging patients before noon. So we had goals to improve our discharge before noon, but how do we have goals when we have no process that was set? It didn't make any sense. We can't have no process, but say you have to improve your discharge before noon. So realizing that we had no formalized process led us to actually developing a process, which then we could keep everyone on page and accountable for their pieces of it. We also found that discharge orders were written on patients who were not medically ready for discharge. We had patients that had orders for discharge every day for 2 weeks. They had no place to go. They had no rehab bed that accepted them. So why were we writing discharge orders, working on the discharge, if the patient had nowhere to go? We weren't really doing a good job document that. So part of the education outside of this was to improve our discharge delay documentation. And we actually improved that by about 63% with some focused education. Put those discharge delays in TeleTracking to allow us to see what the problems are so we can make process improvement. And the last one, discharge patients often waiting on transportation. So we found patients, we always had a discharge lounge. It was successful, not to the amount it is now, but we found that patients, when we got those delays started being entered in TeleTracking, that we found they were waiting for transportation or waiting for meds to beds or waiting for equipment when they were eligible to go to the DHC. So why were they not going down to the DHC? So we had to change the process around discharging patients waiting for those items to utilize the discharge lounge. So our data, our pre-pilot data, so we chose 3 units, and this is where it comes back important about the residents and not residents. So 6A and 6B are downtown campus. They are medicine units specifically. So being an academic medical center, we have residents in these 2 locations. And then 4 North is our community unit that does not have residents, so it's attending driven only. So we picked these 3 units. One, because 6A and 6B were medical, 4 North is a surgical unit. So we wanted the difference between med and surgical areas. We also wanted to see if there was a difference in having residents and not having residents. So we picked these areas strategically for those reasons. We also wanted to see the effects at each hospital and how they were doing. We knew that community hospital typically had a better discharge before noon, which is seen here, but overall the hospital as well, it was better than downtown. So we wanted to kind of investigate that a little bit and see if we can come up with any reasons to why that was and see how we can implement that moving forward downtown. So discharge before noon, both 6A and 6B were at 9% discharge before noon before the pilot. So that was our baseline data. Community at 4 North was obviously better at 16%. So we kept track of this metric to make sure that this was one key metric that we wanted to focus on moving forward. So our interventions, there's 5 interventions. I'll go into depth into these interventions, but creation of a 24-hour discharge process. We realized that it shouldn't just be the discharging nurse that does everything for the discharge. And it really shouldn't be at the time of discharge. It really needs to start 24 hours. We often hear people say it starts at the time of admission, which it does, but to an extent, we wanted to actually create a 24-hour discharge process that starts the day before to do the things that are really needed to get done for discharge. We obviously know that if they're going to a facility that starts a lot sooner than before 24 hours, but this super focused us on areas that we could address within those 24 hours prior to the discharge. We implemented discharge lightning rounds. These are super awesome communication tool. I'm really excited to share these implementation with you guys here in a little bit. The evening night shift discharge prep checklist. This was for nurses. We also realized that our evening and night shift nurses had the capacity to help us out with some discharge planning and discharge prep that they didn't do otherwise. Why shouldn't they be included in the discharge just because they're not discharging the patient? So there's definitely room for opportunity there. Then the implementation of our priority discharge appointments. So these are set appointments, and I will go into detail, but set appointments for discharge for the patient to leave the next day. And then obviously increasing the Discharge Hospitality Center, or DHC, as you might hear me call it, utilization. Because we knew with those discharge delays being entered in TeleTrack, and we knew that we were underutilizing the DHC. So we wanted to make sure that we corrected those processes to improve the DHC utilization and get those patients down to the DHC, which opens up those beds sooner for patients that are waiting for their care in those special locations to get that care. So this was our 24-hour discharge process. I'm not going to touch on every word here, but it basically starts in the morning at 8:15 to 9 o'clock was what we chose on these 3 units. And I will say for teams, for 6A and 6B, we chose 3 primary medicine teams that admit to those floors. So team 1, 2, and 3. So we start the day with multidisciplinary rounds where the team comes, the resident comes. We do a quick overview of all patients, anything pending in the goals, and we update that EDD at that time. So if the estimated date of discharge is different than what is projected, we update it in the system and TeleTracking right then and there. And that way everyone on the team knows when that patient is ready for discharge. And they should not be an hour, they should not be an hour and a half. We found our rounds were going very long in the morning. We cut it down to 45 minutes, and we have a scripting now that we follow for every patient. We go through all the patients on both units, and we're done in 45 minutes, or sometimes less, sometimes we're done in 30 minutes. The lightning round. So this is a case manager led lightning round. It includes the charge nurse, the case manager, and the attending for those specific teams. So they are discharge focused rounds. We only talk about discharges for the next day. We don't talk about all patients. It should only be 10 to 15 minutes total. You should 1 or 2 minutes per patient. You talk about those barriers to discharge, identify patients that can leave before noon, and communicate what tasks are still needed and who needs to work on them. So improving communication, back to our mission statement, how do we improve communication? We have a specialized meeting just to talk about discharges and what needs to be done and who needs to do it and who's going to do it. And then we also knew it was important that that day to night charge handoff, they needed to be able to communicate what was done and what's still pending for, and what are those barriers for discharge. If the night charge didn't know what the barriers for discharges, well, then they weren't going to work on them. So how can we have them included in the process? They didn't even know what the barriers were. So we changed that process and identified those barriers in our discharge process. And then again, work on those next day discharges, doing that pending pre-work. And then that it goes into our evening night shift, that pending pre-work, confirming those 2 priority discharge appointments with the patient and family. I'm going to go into more detail with that in a little bit. Do some med teaching, do vaccines if they're pending, review the med rack. So different things they can do to prep these patients for the next day. And that continues into the night where they review the AVS, which is our after visit summary, the discharge paperwork, med rack for completion. So make sure that the medications are correctly on there. If there's errors found, we didn't want them to call the night float who's just covering. So we wanted them to mark it and let the day team know what errors are found so they can be addressed first thing in the morning. Complete any remaining tasks, and then make sure that we did find that our medical equipment, sometimes we didn't have scripts, sometimes med to beds weren't sent. So ensuring that information was sent, and if it's not, we can update the day team and know that that thing needed to happen first thing in the morning, because we found delays with that as well. And then back to the day shift handoff from the night shift, what was done? So what did you guys work on overnight? What is still need to be done for these patients to leave, which completes our cycle of a 24 discharge process. So if the day shift doesn't know what was done and what was pending, then we failed because they couldn't focus on what needed to be done to get those patients out. And that charge, and being that coordinator of that unit, can facilitate those items being done. But if they didn't know, it wasn't done. So coming in back to making sure that we close that loop of communication was super important. So this 24-hour discharge process is something that happens continually. So there's always a new set of patients. You know, if a patient was selected today, they didn't go until tomorrow, they're still on that list. You're still going to follow through with what needs to be pending. So just close the loop on communication all around, which included this 24-hour discharge process. So lightning round. So these were set up, again, 1 to 2 minutes per targeted discharge patient. So it's only patients that are going to go home the next day. Quickly, what's their diagnosis? What's their anticipated discharge time? What is left over for that patient to leave? Do they need standing x-rays at 6 o'clock in the morning? So if we know what is needed to be completed, we can have the correct follow-up done so those patients can leave. Are they going to be a discharge appointment? If so, is that time in the system? And I'm going to go into further detail about the PDAs here in a little bit. But this is where it's important to come back with the patient and family and discuss that. Does the patient and family know they're being discharged the next day? This is another issue that we found. Someone would come in and say, you're going to be discharged the next day. Someone else would come in and say, you're not going to be discharged until 2 days. So having those focus lightning rounds, focus the entire team on who's actually leaving that next day. And then at that lightning rounds, we also communicate who's going to communicate with the patient and family to let them know that they actually are going to be discharged the next day, which was super important for us. So it kind of fell to, if it's the patient's going to facility or going home with services, case management would let the patient know that they're going to be discharged the next day to whatever facility at whatever time. The patient's going home and went back to the physician to make sure that the patient and the family had that communication that they are going to be discharged. Can they go to the discharge lounge? We need to be looking at, are they appropriate to go? And if they are, let's start that planning process to mark them so that people know that they can go there. So another big thing that with our case management team was confirming that discharge transportation. So if they're not going home with family, who's our vendor for discharge information, who's going to take that patient, what time are they coming, and what the vendor is. So we actually built into our TeleTracking consoles on the nursing list that case management can enter right in the consoles, who the transport vendor is and what time that pickup is. So it just improved the visibility and communication back to our team from case management. So now they can see at any time they are in teletracking what time that pickup is for and who the vendor is, so they know who to expect when that vendor comes to the unit and say, hey, I'm here to pick up X, Y, and Z. And so they know upfront on that transportation, which was a huge benefit for us. And again, back to that task, what is left and who needs to do it? So this is super important to close that communication the entire time. Device removal. Do they still need to be on telemetry if they're being discharged tomorrow? Do they still need to have their catheter in, or do they still need an IV pump in the room when they're not getting anything IV? Start prepping that patient by removing those devices. Getting the PIC line removed the day before instead of the morning of, and if PIC gets backed up in the morning, then it delays your discharge. So starting that prep work the day before, stuff that the patient no longer needs, but we can start moving that stuff out of the patient's room to help the patient know that we're moving towards discharge. Also, get those devices back in use and circulation. Telemetry packs, sometimes we run out of them, we don't have enough. So getting them off those patients and getting them on patients that need telemetry is really beneficial for us. Consideration for early meals and education, especially if it's family education surrounding discharge, making sure that the family is included. You have those conversations the day before or the couple of days before about what education is needed. So that way the patients and families are prepped and ready to go. So this is our prep checklist. This was for the evening and night shift nursing staff. So it was very important for us that they worked with the group, and we actually had night and evening shift staff at our discharge readiness meeting up front. So we wanted to hear from them specifically what they could help us with. And this is the checklist that we came up with. So again, confirm those pre-noon discharges, communicate with patient and family for planned discharges. So we wanted to make sure that the night and evening shift had that follow-up conversation about the discharge, for the next day. We found that it was important that we reinforced what was said in the day shift. Yes, you're going to be discharged tomorrow at 2 o'clock to X facility. We wanted to reinforce that with the patient and family on the evening and night shift. So that way to continue conversation and communication back to the patient and family. So they knew, they understood what was happening, and nothing was a surprise. We also called, if the family was going to do the transportation, we called to arrange and verify that transportation and confirm that appointment time. AVS, again, look at the AVS, look at the MedRec, that discharge paperwork, making sure everything is correct. We often found that our discharge paperwork needed to be reprinted the next day because there was an issue on it. So we can correct those errors, find them at nighttime, alert the day team, they can fix those areas that are incorrect first thing in the morning. So having this checklist actually helped the bedside nursing staff with their processes. They knew what they need to work on. Remove those equipment, we talked about that already, those tethers, IVs, telemetries, restraints, catheters, et cetera. Get the stuff out of the room, they don't need it. Move that patient, progress them along towards discharge. Ask our ancillary services, so our ATTs, our healthcare technicians, to help pack up the patient. Some of our patients have been here for an extended period of time. They have a lot of belongings. We shouldn't wait until transportation gets here to pack up their belongings. Most of the stuff doesn't need, it isn't needed overnight. So let's start. Let's pack up the patient, get them ready to go. So when transportation gets here at 9 in the morning, we can just load up that patient and go. Also, a subset of our patients had AM labs ordered before discharge, which is fine, but we were finding they were drawn late and we're delaying discharge because the results weren't resulted. So let's get those labs ordered earlier and drawn earlier so they are resulted for the residents or the attending to see first thing in the morning to ensure that whatever they were looking for in the labs is good before discharge, because we didn't want to delay our discharges because we were waiting on labs. If it's a patient going to facility, let's get them bathed early in the morning or the night before, making sure that they're cleaned up, they're good, they feel good, or setting them up in the morning early if they can do it themselves. So we want to make sure that our patients leave our hospital with everything, looking good as they can as they're leaving our hospital and feeling good as well. That was important to us to make sure that the patients had that ability. We didn't want to send our patients out of here not looking good, not feeling as good as they could. And again, go back to identifying those patients for the discharge lounge and confirm those DME orders. and then close the loop and relay what was completed and what still needs to be completed to the day shift. So making sure that loop closure is done on communication was essential. So discharge appointments. So this was our big push. So we wanted to set discharge appointments for patients. In essence, this works like you're discharging out of a hotel. You have to be out by 11 o'clock and everything has to be done so you can leave your hotel room. So what we wanted to do is change that model and say, we know these patients are going to be discharged tomorrow. We know they have a standing x-ray at 6 a.m. As long as that's cleared, they can be discharged. Let's set a discharge appointment so we know everything has to be completed by that time. Transportation's arriving at that time, so everything is done so that patient can leave. So we work to do no more than 2 to 3 appointments per team prior to noon, and we set the times a half an hour apart. So we gave options of, we started at 8, but 9, 9:30, 10:30, et cetera. Every half an hour apart. We didn't want to put too many at one time, so we spread them out. So then what we did is when we identified those patients that were going to be discharged before noon, we took those appointment times, went back to the patient and family and offered them an appointment time for their discharge. This was after the case manager or after the physician already told them they're going to be discharged. And we went back in the room and say, you're going to be discharged tomorrow, pending your standing x-ray or pending your labs, pending X, Y, and Z. We have discharge appointments that we would like to discharge you by the hospital by. We have 9, 9:30, 10:30 available. Which time would work for you and your family to coordinate for transportation? So that gave that patient and family back into our process, which was super important for us. It gave them part of the discharge planning. They became part of our team to help select that time, work for us. Now we kept it in a range before noon because that was our goal, but giving them a time actually improved the communication from the patients and families. Oftentimes we were finding patients being discharged, but the family didn't know they were going to be discharged, so couldn't pick them up until after work. Now with a set discharge appointment, we knew up front, we could communicate that to the patient and or the family, what they chose. And this was the expectation that all their discharge work was going to be done for this time. So you can pick them up at whatever your discharge appointment time is. This worked really well. Patients and families were really excited to be part of the process. And they were actively picking the times. In the first few weeks, nursing staff immediately just picked the times and didn't go back to the patient and family. So we went back and re-educated on that piece, and then went back in and had those conversations with the patient and family. And it was much better. We hit our times, our appointment times much more when we included the patient and the family. So once that time is selected with the patient and family, we then notify the entire team of the appointment time. So the physicians, case managers, the charge nurses, the bedside nurse, whoever needs to know for whatever needs to happen. And then we enter that date and time into teletracking so everybody could see it. It's there. And I have a video of that. I'll show you in a little bit. But so everyone, it was visible and everyone knew that. Again, the evening night shift supported that. They do that task, that they do the checklist and remind the patient family of that discharge time, which was super important, that communication back. So then we also found our DHC was underutilized. We were averaging, quite a lot of patients, but we still found through our discharge delays and teletracking that patients were still eligible that were not going down. So it was kind of, the DHC was set up as, hey, this is the tool for you, use it if you need it. So we changed that mentality. Instead of being a tool, use it if you need it, we're going to require all patients to utilize the DHC unless they're meeting the exclusion criteria or if their ride is actively waiting in the traffic. So we often heard the ride will be here in 5 minutes. They don't need to come to the DHC. Well, that 5 minutes turned into 30 minutes, turned into 45 minutes, turned into 2 hours. So if the ride is actively in the circle, they don't have to come down. If they meet exclusion criteria, which is listed here, they don't have to come down. Otherwise, all patients go through the DHC on the discharge. So it was a part of the discharge process. So that's step one of improvement of the DHC. The second step was actually marking in teletracking and capacity management suite appropriate or not appropriate for the DHC. We were finding that patients weren't being marked, so the DHC staff would have to go through the entire discharge list for the entire hospital and look to see who was appropriate and not appropriate, taking a lot of their time. So we went back to the nursing units and said, we need you to mark your patients appropriate or not appropriate when they are in a pending or confirmed discharge status. So pending is the next day and confirm if they have a discharge order. So that was our step 2 of improvement of the DHC, is making sure that the staff in the DHC knew who was appropriate and who was not appropriate. And the third thing we did, if the patient was not marked appropriate in teletracking, we had that DHC nurse give 15 minutes after the discharge order is placed and then call to find out if the patient was appropriate or not appropriate. We did find that initially the DHC nurses were calling the minute the discharge order went in. We worked with inpatient nursing staff and said, give us 15 minutes, let us review it. If we didn't mark it prior, maybe we didn't know this patient was leaving today, give us 15 minutes, let us review it, we'll mark it. And then the DHC nurse can call from that point to see if that patient is eligible or not eligible. So our education, we essentially had a PowerPoint presentation that went out in our educational Blackboard, what we use for everyone to do. We also did in-person education. We did individual education and in groups. We wanted to make sure we touched everyone that we could. So that's why we did individual. If someone couldn't make it to a group session, we made sure we reached out to them individually and had that discussion. And then we have a couple of videos here that hopefully going to play here that shows you what it looks like in teletracking that also was used in education. And this is on our priority discharge appointments.
Hello, my name is Sarah Allen. I'm the principal trainer for technical applications, primarily teletracking. Today we're going to look at how to set a priority discharge appointment or a PDA. Let's take a look.
Hey, Kyle, we can't see your screen.
We have the ability in teletracking to...
Thanks, Kyle.
Okay, 1 second. Can you
make an appointment?
Perfect. Yep.
Thank you.
For when a patient is going to be discharged. We call it a PDA. This is currently piloted at many units here at Upstate. And let's take a look how to do it. So all you have to do, the very first row in teletracking, it looks like a bullseye. If you hover over it, you'll see it says PDA. And this is really an appointment for a patient to be discharged. So any discharges that can leave the next day can leave before noon. We're going to select the icon and the row next to it, this date column. We're going to select it, and notice it gives you an option to set the date. We'll set the date for tomorrow, and then to insert the time. All you have to do is select save. I think that was 2 clicks. And now notice how we see that there not only is a bullseye, but there's a date and time for the patient to leave. So an appointment for them to leave the hospital. This is really important for throughput, and this really is for everyone to be aware when the patient is leaving to help throughput and get more patients through the hospital.
So that was our PDA education, and the second one is about our DHC. And I hope you can see this one.
Yes.
Okay.
Hello, my name is Sarah Allen. I'm the principal trainer for technical applications at Upstate, primarily teletracking. Let's take a look at how to indicate if a patient is or isn't eligible to enter the Discharge Hospitality Center, the reasons why, and also how to view that they've been accepted to the DHC. Let's take a look. So we are viewing our test patient here, and once you've navigated to your unit, you'll notice this navy blue column titled DHC. Selecting the icon next to the patient in this row will give a list of options why they are not DHC eligible. Could be behavioral, droplet or contact, non-ambulatory, protective isolation, etc. So if they are not a DHC candidate, simply select that reason and select save. However, if they are a candidate to the DHC, it's really important to simply select that green check mark and select save. That was 2 clicks if you're keeping track. And now everyone knows that they are a DHC candidate. It's also important to indicate why. Could it be transportation, DHC meds to beds, or DME medical equipment? Let's select a reason. Now it's up to the DHC nurse to select that they've been approved. Once you, as the bedside nurse, see that smiley face on the patient row. That indicates that they have been approved to come to the Discharge Hospitality Center, and now discussion on transport to bring them down can be taken care of. Thanks for learning.
So that was part of our education process. It's pretty simple in TeleTracking to mark those patients, and that gave a view of who's eligible, who's not eligible to the DHC nurses, so they don't have to try to figure that out on their own. So outcomes and impact, right? So did we make any progress? So looking at 6A, we saw our overall discharge before noon increase from 9% to 12%, 6B from 9% to 14%, and then 4 North from 16 to 17%. So not huge increases, but one area we did find is we're only doing teams 1, 2, and 3 on 6A and 6B, which is only about 60% of the patients on the unit. So we were able to increase discharge before noon, but we're only talking about 60% of the patients, which is an important fact to know. So if we were talking about 100% of the patients, I assume we would have seen a higher impact in that. So then what we did is we looked at, from our first quarter to our second quarter of the pilot, how did we do with specifically looking at our discharge before noon patients? And when we looked at our differences in percentages of discharge before noon, we saw a 71% increase on 6A, a 55% increase on 6B, and a 31% increase on 4 North when we set a discharge appointment. So it was vital. When we set those discharge appointments, we found that those patients went before noon and re-improved from our first quarter to our second quarter, setting those appointments, getting them out in time. So really, really great results when we actually look at specifically just our discharge before noon appointments. DHC. So our pilot, before we were averaging around, and this is on 4 North at community, around 25% of our patients utilizing the DHC. Post-pilot, we're getting 45% of the patients through the DHC. So huge improvement with those changes we made. And then we did a hospital-wide rollout, and the overall DHC volumes improved by 43% at the community hospital. Downtown, we actually did a pilot on 4 units for the same thing. You can see we were 11 or 13% of their discharging patients went through the DHC. We improved from 19 to 30% of the discharging patients going through the discharge lounge, which is really good. Our goal was 30%. So we hit our goal on 2 out of 3. The 10E, we didn't think we would hit. That's our HEMOC floor. There's a lot of patients that aren't eligible for the DHC off that unit, but we wanted to make sure that we included them, and we actually saw an 8% increase there. So we then rolled out to the entire hospital, all med-surg and step-down units, excluding ICUs, and we saw a 34% increase in our DHC volume with those 3 changes that we made. This is a nice slide that shows overall volumes of our discharging patients. So this is total volumes for both DHCs combined for this year. So early in the year, we were in the 260s. We were averaging, in the mid 300s pretty consistently. So after we made the changes, we went live at the end of June at community. We went live the 27th July at downtown. So the first 3 full months of this new pilot, we saw huge growth, 506, 608, and 527. So we averaged 160 more patients over those first 3 months of the pilot compared to previous. We were averaging in the 300. So huge increase in volume of patients going to the discharge lounge, opening up those beds for us, which really helps move those ED borders out and opens up those beds for the ED patients. Outcomes and impact. So the DHC. So this is the first 6 months of the year. This is downtown. We saw over 1,200 patients, average length of stay 72 minutes. And this is where the TeleTracking results management team really came in. They do these calculations for us to see how much money we are actually saving by using the DHC. So they calculate what our med-surg insurance payments are for med-surg, critical care, PACU, ED, all those areas, how much time the patients spend in there, and how many bed days we saved, and what the net DHC savings is. And that net DHC saving takes out the nurse's salary and benefits. So we calculate that with the nurse's salary and benefits out. So we saved over the first 6 months of the year over $119,000 just by using the DHC, which is really, truly remarkable and phenomenal, especially in the time in the financial market that the healthcare marketplace is in now. And then looking at our community campus, 831 patients, 48 minutes average, so over $41,000 we saved in the first 6 months. And I'm really excited to see the results management team do this July through December with our increased volumes to the discharge allowance. I can't wait to see the new net savings over the last 6 months, because I know it's just going to explode. And I will tell you that our chief financial officer loves seeing this information, and I really thank the results management team for putting it together in a way that can be displayed back to our hospital officers, that's easy to understand and shows the significance of the DHC and how effective it actually is. So follow-up. So what did we learn? So there's a few things that we learned throughout the process. In-person lightning rounds were very challenging for us. We had to coordinate all these people getting in a room together. So we changed that method from an in-person meeting to a virtual format and open it up from the hours of 2 to 3. So a virtual format where we do the same work, just virtually. Everyone can jump in and have the conversation. And it's actually then listed out in a virtual format. We can track it better. So that actually worked really well. We also found that we needed constant follow-up and education back to the units as new staff come on, as we have travelers that they need the education. So we need to make sure that we keep rounding in these areas and keep the education back up. Also, the units wanted the data. For whatever reason, we weren't sharing the data up front, and they were asking for it. So then we got reports developed specifically around PDAs and how they were doing. So make sure you bring that data back to the units, as they found that to be the most effective thing is actually seeing the data along with the patient stories for good outcomes. So next step, so what are we going to do next? We're going to roll out the 24-hour discharge process, including the lightning rounds and PDAs, to the remaining hospital units. So we're talking about how to do this step now, and we're going to roll out the new DHC process in early December to the pediatric units. We average about 5 to 8 pediatric patients a month in the DHC. We're looking to improve that to 25 to 30. They stay about 45 minutes. So we're looking to open up, 10, 15 hours of bedtime. Those pediatric, there's not a ton of pediatric patients that are actually eligible with the DHC, but we want to make sure the ones that are coming down, so we can open up those peds beds a little bit easier, as our peds volumes are definitely exploding over the last several months. And with that, I'm going to turn it back over to Maria.
Well, Kyle, you had me sitting here in full suspense to see these outcomes, and I've seen them quite a few times, and it's so exciting. But every time you tell this story, it just gets better, because you really have improved access of care for those patients that are waiting to get into those beds. And I want to thank you in the midst of COVID, in the midst of what you're facing right now with full capacity with the RSV. As you explained this week, you have a full capacity there. You still took the time to be able to share with other clients. And I'm sure if you raised your hand, how many of you want to have outcomes like this at your organization? So thank you, Kyle, very much. I have to tell you, Kyle never lost track, and his team, Tracy, who works very closely with him, never lost track of the vision, the mission and the vision for what they were trying to solve for. And they made sure there was education, as you can see. They made sure everything was tied down for the success, because they had that mission statement and the vision statement of what they wanted to solve for patients. So please, everybody on this call, don't forget that. Now we have a lot of questions and you're going to answer those, Kyle. So the first one comes from Denise Field. Does the team have teletracking open during the rounds and shift change?
Yeah, so that's an excellent question. Originally, they did not. And then when we started those inpatient lightning rounds, we actually brought our computers on wheels into those rooms and opened up teletracking. So that way we could update in real time that EDD if that needed to be done, put any discharge delays in that needed to happen. So initially, no, but then as we progress along, yes, which has been extremely beneficial.
Okay. So Denise, I hope that answered your question. I'm sure quite a few others had the same question. The second question comes from Cassidy Bibb, and that is, this is great and mirrors a lot we are working on currently in my system. Did you have any issues with doing medication reconciliation / AVS the night prior? Our physicians are pushing back as there is a rework piece. If any consultants make changes to the med reconciliation after it's complete, do you have a solution for this, or are you affected by this with your version of Epic?
Yeah, so that was a concern that the physicians brought forward, but we weren't necessarily making changes to the MedRec. We were looking for errors more specifically. So they're going to go into the AVS. They're going to look to make sure the discharge follow-up appointments are there. They're going to make sure that their MedRec closely matches what's being ordered in the hospital. And things that were ordered from home, say metformin that we don't give them the hospital, the patient has is on the discharge paperwork. So they're more looking for errors. They're not actually making any changes to those MedRec or AVS. They're looking for any areas that stick out and speak to them. And then they notify the day shift team, who the day shift team then follows up in the morning with the resident or the attending. We did find that was a better process. Initially, they wanted to reach directly out to the night float, who had no idea about the patient because they were covering 300 patients. So following up the next day and say, hey, I think this is an error on the AVS. Can you take a look at it? Actually worked well for us. And it worked for the physicians as well. The residents actually preferred that, and pointing out the errors that are potential errors to find that up front until the moment the patient's transportation was here, and then calling frantically saying, I need this changed because this was an error. So there's a little more proactive approach. We didn't actually change anything, but it just facilitated the communication for us.
Okay, and Cassidy has another question. Did you leverage Epic or TeleTracking for your checklist, or were they on paper?
So the checklists were actually on paper. So it was designed on paper. We have talked about putting it into TeleTracking. We have yet to do that. It is not an Epic either. So currently it's on paper. They simply print it out, fill it out, and leave it in the front of the patient's room or outside in their binder, and then throw them away. We are looking at the process of putting it into TeleTracking.
Okay. Jesus Riveral, who is driving this process? Is it the charge nurse or the case manager or the floor? I understand that it is a joining effort, but who drives it literally?
Yeah, and that's a great question. Literally, the lightning rounds are driven by the case management team. So they lead the lightning rounds. Tracy, that Maria talked about, who's our patient flow administrator, is actively involved in all those conversations. So she helps drive. If the case managers start leading something and there's the physician hasn't spoke up, Tracy reaches out to that physician team to facilitate them being active in the chat. So it's really a multidisciplinary team. Usually the case manager, if they don't see it, they might reach out to the physician, or if physician's in there and they need case manager and they're not in there, they'll reach directly out to the case manager. So everyone's really bought in to the process, but really it's the case managers leading those lightning rounds. And then from there, the nursing staff is leading, setting those appointment times and notifying the team.
All right, and Jesus has, who identified the discharges? Where is it provider in this process?
So the discharges are identified by the provider. So they are in the lightning rounds. They tell us what patients are going to be discharged the next day and what is pending for those patients. So this process doesn't work unless we have the providers bought in and they provide us those discharges or potential discharges pending X, Y, and Z. Okay.
And one more from Jesus. Is your DHC staffed by a clinical associate?
So our DHC is staffed by registered nurses. So our DHC staff, they're in a dual role of that throughput team, which does the admission and discharge histories I talked about earlier, and they staff the discharge lounge. So they're fully functioning nurses that staff our discharge lounge.
All right, Sean Mabry wanted to let you know, job well done, Kyle. Karen Birchfield, great. I love this. Great work. Denise Field, thank you. Karen Birchfield, where in TeleTracking could this be captured?
Where could what be captured exactly?
The checklist.
I'm hoping care progressions.
Yes, and we did talk about that, and we have some active work going on, and we're hoping that that is exactly where you're going to be able to capture this. So Karen, we are going to follow up with part 2 of this webinar series to see how we identify that checklist. And then Jesus has another question. How many nurses do you have assigned to the admission/discharge team? Is that an 8 to 5 team, 7 days a week? Can you tell us about that?
Excellent question. So our throughput nurses /DHC nurses, we have 5 0.2 FTEs, 6 people, but really 5 full-time and a per diem person. So the DHC is staffed Monday through Friday, 10 to 18:30 at community, Monday through Saturday, 10 to 18:30 at downtown. So really you're taking 2 FTEs just to staff the DHC. That leaves 3 FTEs for throughput. And they work the hours of 10 to 10. So 10 in the morning and 10 at night, which is our busiest times for throughput. In most cases, we have 2 throughput nurses downtown and no one at community. The volume of throughput at community is relatively small compared to downtown. So we found the benefit to have 2 here.
And then Tabitha Matthias, how many patients are you able to care for in the DHC for each?
So community DHC can do 6 patients at a time. The downtown DHC can do 12 at a time, with their length of stay around 50, 55 minutes. They turn over pretty quickly. So we never really get we never have to turn away patients. I'll tell you that. We've had 30, almost 40 patients in the downtown one, but they just come in and out relatively quickly. So it works out.
And then Kyle, maybe quickly, you can just talk about that space for the DHC, because I've heard multiple times that the hospital has no space to have a discharge lounge.
Yeah, so we did 2 different things at each hospital. So downtown, which we started our DHC back in 2019, we actually took over a small cafeteria area. So it was where people ate their lunch. We have a large cafeteria, but this was a small room off it. So we took that over. It's on the 2nd floor. So it's not even on the 1st level where our front circle is. But it's a beautiful space where we renovate it. There's lounge chairs in there. There's TVs, there's food, there's water, there's drinks, there's snacks, magazines that we have donated to us. So it's really a comfortable area for patients to sit. They can watch TV. They can make calls. It's pretty nice area. And then over at community, the gift shop actually moved out, and very quickly we commandeered that space. And turned it into our discharge lounge. It's a very large space, so we split the space. There's a little food vendor in the corner now, but we have that space, same thing, TV, lounge chairs. It's just a really nice homely space. So really excited that we have both those spaces. And that one is right outside the front circle. So it's very nice for our community. They can just push their patients right out front.
All right, great. I don't think we have any other questions, but I do want to just open it up to Lisa or to Mike if you would like to add anything in from the work that you did with Kyle and his team.
Hi, this is Lisa with Advisory. I just wanted to say that part of the most impactful outcomes that were driven by the discharge readiness engagement was really the engagement of the teams, the fact that it was so multidisciplinary and that they created it. And I think that is a testament to the culture, both at Upstate and the process. You know, when you bring your teams in to really create the process that they're going to be using, it really drove that adoption. And I think that was just something very powerful that came out of that.
Thanks, Lisa. And Mike?
Yeah, along those same lines, really the Upstate team, I would say they're really the heroes in this, right? We certainly provide guidance. You know, we meet with Kyle and team on a quarterly basis and review performance numbers and so on. And but when we talk and work through what needs to be worked on and what the numbers are saying and where their initiatives are, it's them really taking action and taking hold of the numbers and taking hold of the guidance and so on, and they take action. And I think that's the biggest thing to take away here. TeleTracking is great on the guidance and knowledge and support and technology, but you have to use it. And Kyle and his team are really great at that.
Yeah, thanks, Mike. That was great to share, because they were like a sponge, and they really did want to know what the guidance was from our best practices. And then they utilize that with their current culture, and they brought their culture in. Kyle, you know, and your Tracy, Tim, you know, the team members that you've worked with, and I know I'm leaving out a few, but you really are culture changers for your organization. In today's healthcare society, we're losing $33.7 billion on avoidable days across America. And you are cutting away with this, you know, and I really am grateful that you are partnering with us to do this. And again, I thank you for the time that you spent on this webinar, because we really had a good turnout of over 71 people, and that's 71 different organizations that attended. So thank you, Kyle. And for everybody that attended, this will be posted on Knowledge Bridge, so you can share the goodness with all of your colleagues. And if you want to raise a hand, and if you want anyone from the TeleTracking team to get in touch with you to replicate this at your organization, we would be more than willing to do that. So you can just put your hand up and we will be in contact with you. Otherwise, thank you for your time, everyone. Have a great day and stay safe. Bye.